Good morning, good afternoon, good evening to everybody joining us, and welcome to our webinar on the facilitators and barriers in the implementation of a digital surveillance and outbreak response system in Ghana before and during the COVID-19 pandemic. We're delighted to have you here and also delighted to have our guest speaker, Dr. Basel from the Helmholtz Center for Infection Research, joining us today. So just an overview of what you can expect from this webinar. We have our welcome and introduction session, which will be followed by the presentation. After that, we will have our question and answer session, and then we will close the webinar today. So please note that the webinar will be recorded. However, no participant images will be shown in the video. Our question and answer session is also separate, so it will not be part of the video. At the moment, you are all muted, and you will be able to unmute yourself during the question and answer session. Your camera is also switched off. You are, however, welcome to ask questions in the chat. So as the presentation continues, please feel free to type your questions in the chat, and our team will be able to collect that. So thank you to Monica, Dennis, and Christine for assisting with that today. So into the main attraction for the day, Dr. Basel, over to you.
Thank you, Candice, for the warm introduction. I would like to confirm if you are able to see my screen.
Not yet. You can maybe try to share again, please.
Okay.
Perfect. We see your screen.
Great. So I also welcome you all to this presentation, a summary on the facilitators and barriers of the implementation of SORMAS in Ghana before and during the COVID-19 pandemic. So the agenda for our discussion today will go through the background of the research, through the results, to discussion, and the outlook for implementation of SORMAS. My understanding is that participants of this webinar are keen stakeholders on digital disease surveillance systems for outbreak response as well as routine surveillance. And we understand that the timeliness of reporting and quality of data is highly enhanced by these systems. And these systems also enable us to integrate surveillance in various components from the field, the laboratory, clinical, and many more. And the overall process management of our outbreak response. The implementation of these systems, however, are particularly challenging in low middle income countries. And funding is one factor that intertwines the sustainability of these systems. And the leadership of our system also has a role to play in these implementations. To a larger picture, we also understand that public health systems in Africa are also underfunded. And this now requires that the limited resources be efficiently used. And the efficiency of use of these resources will require some context-relevant evidence. And so that informed efforts to study the formative stages of the implementations of these systems, see what relevant context evidence we could get to support the countries implementing and other countries that are considering the implementation of similar systems. So the case in point here is the implementation of SORMAS in Ghana. And for guests who may not be familiar with SORMAS, it's the Surveillance Outbreak Response Management and Analysis System. So we sought to answer two main research questions. The first is, as captured in the title, on the facilitators and barriers before and during the COVID-19 pandemic. And the second is to solicit sustainability strategies from the perspectives of the stakeholders that we interviewed. To the methods of the research, it was a qualitative study, and we interviewed a sample of 22 stakeholders from across 7 broad professional categories, including the developers of the system, the users, and some public health experts involved in the implementation by way of advice and also the training of workforce. And for the users, we consider users at the national level, the regional level, and also those in the laboratory, mostly in the regional and national levels. We also considered administrative staff, as well as those frontline workers who are in direct contact with the tool and doing all the data collection and analysis. So we modeled the evaluation of the implementation in Ghana. What I mean is the evaluation of the implementation, we modeled it after the model for the fusion of innovations in health service organizations, which outlines the various implementation domains that have to be considered in evaluating how successful or challenging evaluation implementations are. And we conducted telephone interviews due to inability to travel and isolation during the COVID-19 pandemic, because the study was conducted between November 2021 and March 2022, and that was the peak of the lockdowns. So we transcribed recorded audios and had them validated by a second person to be sure that the transcriptions were accurate, and we performed pseudonymization of the transcript to take out personal identifiers, and we then did coding according to the model of implementation, the evaluation, and finally performed a thematic analysis of the results, the data. So this was my workstation during the interviews. And now I would like to give you a summary of the results. So looking at the implementation domain, that's centered on the innovation itself, in this case, how SORMAS was designed. Its consistency with the integrated disease surveillance and response, which is used in Ghana and the WHO Afro region as a whole, was one factor that made it easily acceptable, because then it was just a digitalization of their familiar work processes. So it didn't have to come with a lot of changes, and that was a good facilitator. The second was its relative advantages over the existing systems, to the extent that it was able to collect case-based data, had an offline mobile use capability where you didn't need internet to collect data, but to collect data in the field. And subsequently, with internet access, you can synchronize your data with the rest of your databases. And how it integrated the surveillance system in the field, in the laboratory, and the clinic, making the data more holistic and ready for analysis and decision making. Barriers to the innovation had to do with the data hosting capacity of the Ghana Health Service having to have their own IT center that is able to host the data from the system, from the field and the other components like the laboratory and the clinics. And then the interoperability with the existing database, the DHIS2, also came across as a barrier. Then in the adoption process, the organizational leadership was strong to the extent that they had to be courageous enough to take risks. And then subsequently, given the onset of the COVID-19 pandemic, the political hierarchy had to take responsibility also and find a tool that could help with the management of the pandemic in the country. And so then we got endorsement at the level of the presidency. So in the adoption phase, particularly before the pandemic, there was a multiplicity of digital systems that were used by various programs in the service. And then this took attention from the workers who were supposed to be using various systems at the same time, depending on the disease they were dealing with. And so that was quite a barrier. Now for eSpread, the combination of workshops, that is the didactic sessions with peer-to-peer trainings, came across as very complementary, because then fewer people were able to be trained in the workshops, and they in turn were able to train other workers, their peers, and sometimes even their bosses back in their health districts and regions. And that was also a testimony to how easy and intuitive the system was, such that just after a day of workshop training, you are able to even train other people yourself. And the users of the system were also well motivated, and some were not even assigned to train their peers, but to get the work going and to share the excitement of how the tool was helping with work. They did it all by themselves, sometimes out of their own needs. So device qualities and their number came across as a barrier, particularly during the pandemic phase when the workload was increased and it had to be scaled up rapidly without enough time to plan. And the training this time had to be done in masses, and there were situations where people were in the training and had to share a tablet. So then that didn't go well with picking up the skills quickly as if one would have their own tablets at a time. Then the model of evaluation also looked at the system itself that is adapting the tool, and this is Ghana Health Service adapting SORMAS. The vision of the Ghana Health Service to transform surveillance and outbreak response using the digital innovations that are coming up was one that met with the timeliness of the introduction of SORMAS. And the workers themselves had always wanted to perform their tasks in a digital way, because they had ideas about how other countries in the advanced world were using digital systems. And these users were mostly very smart with smartphones, very literate. And so navigating and troubleshooting during the training wasn't a problem. So that facilitated the implementation. But once again, as a system, the Ghana Health Service, there was limited ICT infrastructure and, for that matter, the expertise. The other context had to do with the support, the implementation obtained from other stakeholders that are not within the Ghana Health Service. And so private institutions within the country supported in terms of logistics and even availing their staff to participate in the trainings. And this was particularly enhanced during the pandemic. From the very outset, it was multidisciplinary acceptance of the system, but in the pandemic, they really worked very well together. Of course, the inventors from Germany and financial support from EU and other stakeholders like WHO, CDC supported the scale-up. For a barrier, notwithstanding the political support at the presidential level, there wasn't any clear-cut directive to the local governments, giving them some authorization to financially and otherwise support the implementations. And given that surveillance takes place at the grassroots, the district and sub-district level, the immediate support of the local government would have been very influential in how well things went. Of course, unstable internet and power supply were factors that limited the implementation, but were outside the mandate and of the Ghana Health Service. So these are countrywide issues. There was a linkage between the developers of the system and the users, and most of the features, updates, and new features that were developed were user-led. And when users have their requests addressed and they're able to use it within days and weeks of requests, then it actually increased the motivation. And the community support on GitHub, where other experts in the field contributed to specifications, was also contributory to the successful implementation. I have a limited experience on the specification by the Ghana Health Service staff. Kind of slowed down some of the feature development because then fewer people had to do the specifications. And lastly, with the institutionalization of SORMAS, so far it's decentralized to all districts, and this open source system means that there are no recurrent costs in terms of the system itself. So these are good for institutionalizing SORMAS. However, the running cost comes up as a barrier because of this underfunding of the health system that I alluded to in the background. Now, a quick summary about how the factors played out before and during the pandemic. So this is the timeline for the implementation, with the pilot starting in November 2019. And within 4 months or so of the pilot, whilst we were still waiting to evaluate the pilot, then we had to scale it up across the country. And so that informed a number of the facilitators as well as the barriers. And this is where we did a study about a year after the pilot, and we quoted the data in this period. So for the facilitators, that persists across both parts of the phases of the implementation. We have the IDSR compatibility and the user motivation and technical support, which SORMAS implementers will benefit from the GitHub and then the inventors, now the foundation. But in the pilot phase, alignment with the goals of the service was key. And in the pandemic phase, the political support and increased partner funding was very facilitating. For the barriers in the entire period is this unstable system interoperability and the limited capacity for data hosting that are still a bit persistent, but efforts are also relentless in addressing this. And for the pilot period, competing digital tools was a barrier, which is now very limited because everybody is using SORMAS for the routine surveillance. And the high demand for logistics and user training were those that showed up during the pandemic as barriers. We also asked these stakeholders who are very experienced in their jobs, some more than 20 years of experience in this job, about what they think would be good suggestions for improving the prospects of sustainability. And we targeted these suggestions to the major stakeholder institutions. So for the inventors of the SORMAS, the users, as you would expect, one that they investigate and stabilize this interoperability issue between SORMAS and DHIS2. So then it's seamless in their tax performance. For external collaborators, they suggest a consolidation of the gains by promoting knowledge exchange as well as skills transfer between the developers in Europe and those in Africa, and also to promote closer collaborations with the service delivery arm of the system and the research institutions, such that the data can be used by research institutions to generate evidence, and they in turn can inform what other good features can be included in SORMAS for more holistic service delivery. To the government of Ghana, they think the government should commit more financially to the implementation, and the issue of political directives for active local government participation came up because they said they didn't have the feel that the municipal assemblies and district assemblies were as committed as the office of the president in the successful implementation of the system SORMAS. And of course, Ghana Health Service took a lot of the recommendation because they are in the implementation arm. So they suggested that they create and maintain a common pool of project logistics because there are several projects also running in the service, such that computers, stabilized and internet modems should not be labeled for any particular project, and they can always be called upon when they are needed for any other relevant duty in the service. And they suggest an active financial contribution from facilities that generate internal revenue, we call it IGF, internally generated funds, that they should also support the purchase of tablets in particular for their institutional surveillance officers. And they're asking for more, even though it's decentralized to all districts in the country, they want it further down to the sub-district level so that they minimize the workload that has to come up from the sub-districts for those at the district level to enter. And to also sustain the motivation and the peer champions in the implementation, they suggest they want to be recognized in award ceremonies, and they want to participate in workshops and conferences where they can also exchange with other colleagues from other countries. So those were the suggestions. Now to the publication that emanated from this research. You can have some more details if you are motivated enough to. And you here also have some quotations of their personal experiences of the use of SORMAS, and some are very uplifting. There's a few that you may sympathize with because of their motivation to use the system and how they get a bit frustrated sometimes because of internet issues. Now, just a short discussion on the facilitators. So the pre-existing testing for change and the demonstrated utility of SORMAS in the pilot phase was one that informed the motivation of the frontline workers. And this concept where frontline workers are willing to make some sacrifices, in this case in terms of their own internet bundles or devices, because of the very benefits they obtain from the system and count not so much of the pains, is well documented as an indication of the usefulness of a system. So in this case, the pains don't count as much as the gains. So then they are happy to sacrifice even if the system has challenges. And this supported the leadership of the system because then their staff were very supportive. The high-level support that came, particularly during the pandemic, was also very motivating in the sense that as a country, when the president and the vice president say that this is the tool we are using for our pandemic response, then even those who were not very motivated get on board, because then the country was moving in one direction and they couldn't afford to be left behind. So this high-level stewardship from the technical leadership of the Ghana Health Service and the political establishment was also reinforcing of the positive attitude of the users and facilitated a lot the implementation. The suboptimal data synchronization was a problem beyond the means of the Ghana Health Service, and to some extent, even the government, to the extent that the services, ICT services, are mostly private sector driven. And of course, then the problem was not a very surprising one, because the ICT services in Africa are well known not to be optimal. And so the inventors as well developed a supportive tool called the low bandwidth database synchronization system, where if in use in tandem with SORMAS, could enable users to synchronize data at smaller or lower bandwidths without having to have the best of internet. And this is in the future going to be the mainstay for settings that have still got serious challenges with internet connectivity. The unstable interoperability, of course, is one that has to be addressed to further keep the work seamless and motivate the users more. Funding bottlenecks and economic sustainability. This didn't come out as a surprise, but it was particularly the case because of the various exigencies surrounding COVID-19. We didn't only have to fight the pandemic by surveillance, but there were other aspects of the economy and the population calling for funding. And so having to lock down people and feed people was part of the response, not just implementing SORMAS. So these further made the implementation very challenging. And the implications of these findings are there for the country as well as similar settings, so that SORMAS is very compatible with the RDSR, means that because the WHO Afro region is using the RDSR, they wouldn't have to do major adaptations in order to use SORMAS. So that is one good thing that SORMAS offers for the WHO Afro region. But this same region uses the DHIS2, and so resolution of the interoperability between SORMAS and DHIS2 will not just benefit Ghana, but all other regions, countries in the WHO region or outside that use DHIS2 will benefit from this solution. The ICT sector challenges that have to do with synchronization and data transfer, as we experience in some instances in Ghana, would be the same for other settings whose ICT sectors have similar challenges. And so in considering the adoption of SORMAS, these should be noted, and the LDBS would be a good assistant in alleviating some of these challenges. Budgetary constraints will still come up, and countries considering it should have the foresight from the experiences of Ghana and other regions to plan a lot more, hoping that pandemics and other emergencies don't derail their stepwise implementation process, which was intended for the implementation in Ghana, but of course was interrupted by the COVID-19 pandemic. So in summary, the success conditions for digitalizing surveillance at scale are the proven adaptability of the system to national needs and even evolving job demands. And COVID-19 had a lot of unknowns, being novel, and so the ability of SORMAS in particular to adapt to user requests depending on how the disease was going was very good. Strong technical support and stewardship sustains the implementation from top to the frontline user. And evidence on implementation scale is substantial, but normally as we saw, cost data is not particularly available for implementations, as those who are busy implementing are probably not the best, don't have the best expertise to do cost evaluation and analysis. And some barriers of the implementation had to do with the whole national development and were not system specific. So some recommendations for implementing countries: funding commitment should be improved and incentivize private sector to participate and pool resources within the health sector and also the private sector. Supporting external partners should endeavor to engage adequately in the beginning and also beyond the piloting process. So there's also sustained, not only financially, but technically. And the outlook of implementation of SORMAS in Ghana. So the ongoing national digitalization agenda promises to be one development in Ghana that will support the implementation of SORMAS. There are some commitments to digitalizing the public health, the public sector, including the health sector. In the case of Africa, EIDS are being adopted across the region, and Africa CDC is also come up with a digital surveillance agenda where they provide technical support to countries that are adopting these systems. Some few references, and we acknowledge our sponsors: the Helmholtz Center, the EU, the German Ministry for Economic Cooperation and Development, and then the Regional Ministry for Science and Culture. And with this, I'll thank you for your attention.
Fantastic. Thank you, Dr. Basil, for sharing your experience, wisdom, and knowledge with us and the audience. At this point, we will be moving on to the question and answer section. However, I would like to say thank you and also goodbye to those of you who joined us via video, just for the video presentation, as the question and answer session will not be part of the recording. Of course, questions can be made at our community platform, community.sormas.org, at any time.